With acute kidney injury, or AKI, there's a decrease in kidney function that typically happens over a few days. This leads to the retention of urea and other nitrogenous waste products, such as ammonia and uric acid, and dysregulation of extracellular volume and electrolytes. The most commonly used diagnostic criteria for AKI are the Kidney Disease Improving Global Outcomes, or KDIGO guidelines. The KDIGO guidelines define AKI as an increase in serum creatinine of at least 0.3 milligrams per deciliter within 48 hours, or as an increase in serum creatinine by 1.5 times the baseline serum creatinine within the last 7 days, or when the urine volume has been less than 0.5 milliliters per kilogram per hour for 6 hours. Based on these criteria, there are 3 stages of AKI, where stage 1 is mild and stage 3 is severe AKI. In stage 1 AKI, there's an increase in serum creatinine to 1.5 to 1.9 times the baseline serum creatinine, or an increase in serum creatinine by 0.3 milligrams per deciliter, or a decrease in urine output to below 0.5 milligrams per kilogram per hour for 6 to 12 hours. In stage 2 AKI, there's an increase in serum creatinine to 2 to 2.9 times the baseline serum creatinine, or a decrease in urine output to less than 0.5 milligrams per kilogram per hour for more than 12 hours. In stage 3 AKI, there's an increase in serum creatinine to 3 times the baseline serum creatinine, or an increase in serum creatinine to more than 4 milligrams per deciliter, or a decrease in urine output to less than 0.3 milligrams per kilogram per hour for more than 24 hours, or anuria, meaning less than 100 milliliters per day of urine, for more than 12 hours, or where renal replacement therapy has been initiated. All individuals are classified according to whichever criteria places them in the most severe stage of injury. Once diagnosed, the causes of AKI can be split into pre-renal, intrarenal, and post-renal causes. In pre-renal AKI, there's decreased blood flow into the kidneys. This can happen in hypovolemic states like an acute hemorrhage, gastrointestinal losses, like with diarrhea and vomiting, renal losses, like with diuretics or osmotic diuresis in hyperglycemia, dermal losses, like with burns, and finally, sequestration of fluid, also known as third spacing, like with acute pancreatitis or sepsis. On the clinical examination, there's tachycardia, hypotension, reduced skin turgor, and cool extremities. Now, pre-renal AKI can also happen with hypervolemic states, where there's a low effective circulating volume. One example is severe systolic heart failure, leading to pump failure, and when this happens, it's called cardiorenal syndrome. In this situation, there are signs of heart failure, like hypotension, fatigue, dyspnea, and peripheral edema. Another hypervolemic situation, due to a low effective circulating volume, is hypoalbuminemia from decompensated liver disease. When that leads to AKI, it's called hepatorenal syndrome. The individual has hypotension and signs of liver disease, like splenomegaly, caput medusae, ascites, and peripheral edema. Additionally, some medications like NSAIDs, ACE inhibitors, ARBs, cyclosporin, and iodinated contrast can damage renal blood vessels, leading to ischemia and causing pre-renal AKI. Next, there's intrarenal AKI, which is due to damage to the tubules, the glomerulus, or the kidney interstitium, which is the space between tubules, or vascular damage. The most common cause of intrarenal AKI is acute tubular necrosis, or ATN, which causes damage to the tubules due to ischemia. Often, ATN is due to ischemia from a pre-renal acute kidney injury. The other way tubules can necrose is by nephrotoxins, such as aminoglycosides, antibiotics, methotrexate, heavy metals like lead, myoglobin from damaged muscles, like in rhabdomyolysis, ethylene glycol, radiocontrast dye, and uric acid. Typically, the individual has been exposed to a nephrotoxin and has associated symptoms. For example, if they've been exposed to ethylene glycol, the individual might also be confused and have dilated pupils. Whereas if the cause is myoglobinuria, they may have had a recent crush injury. Another type of intrarenal AKI is glomerular disease, which is anything that damages the glomeruli. Glomerular disease can cause isolated gross hematuria, like immunoglobulin A nephropathy. It can also cause signs of nephrotic syndrome, such as peripheral or periorbital edema, even ascites. This can happen with membranous nephropathy or membranoproliferative glomerulonephritis. Labs here show that proteinuria that's above 3.5 grams per day, protein to creatinine ratio greater than 3 grams per gram, hypoalbuminemia that's typically less than 3.5 grams per deciliter, and hyperlipidemia with levels of low-density lipoprotein, or LDL, above 130 milligrams per deciliter, and levels of triglycerides above 150 milligrams per deciliter. On urinalysis, specifically microscopy, there's lipiduria, which is identified based on the presence of fat droplets. Or it can present signs of nephritic syndrome, such as arterial hypertension and peripheral edema. This can happen with systemic lupus erythematosus. Labs here show moderate proteinuria, between 1 and 3 grams per day, and on urinalysis, there are more than 5 dysmorphic red blood cells per microliter, and also red cell casts. Finally, it can also present with signs and symptoms of a more severe systemic condition, such as malaise, arthralgia, and fever, like with Goodpasture disease. Another cause of intrarenal AKI is acute interstitial nephritis, which is inflammation of the interstitium over the course of days to weeks. This is thought to be a type 1 or type 4 hypersensitivity reaction, and is typically a response to a medication like NSAIDs, penicillin, and diuretics, such as thiazide diuretics, like chlorothiazide. Early symptoms include fever and rash. Now, vascular damage can be caused by renal artery stenosis, which is when one or both renal arteries are narrowed. This can be caused by atherosclerosis in older individuals, and by fibromuscular dysplasia, which is a non-inflammatory and non-atherosclerotic condition that usually affects the internal carotids and renal arteries in younger individuals. Symptoms include persistent arterial hypertension despite taking antihypertensive medications, and sometimes peripheral edema. Finally, there's post-renal AKI, which is due to an obstruction to the outflow of urine from the kidneys, which causes a buildup of urine and pressure that backs up into the kidney. This is most frequently due to benign prostatic hyperplasia, or prostate cancer in a male, both of which lead to compression of the urethra. This can lead to frequent urination but a slow urinary stream. Other causes include intra-abdominal tumors that compress the ureter, in which case the individual can present with unintentional weight loss and fatigue. Finally, there are kidney stones that can get stuck in either ureter or in the urethra. Now, if only one ureter is obstructed, called unilateral obstruction, and the other kidney is working fine, then renal function is usually preserved. But if both ureters are obstructed, like when there are stones in both ureters, called bilateral obstruction, or if the urethra gets blocked, then we've got a recipe for post-renal AKI. With obstructive ureteral kidney stones, the individual has renal colic along with anuria if both ureters are completely obstructed. With urethral stones, the individual has pain in the urethra and anuria. Now, additional labs include creatinine levels in order to calculate the estimated glomerular filtration rate, or eGFR, BUN, CBC, and electrolytes to check for hyperkalemia. Hyperkalemia can develop because when the individual is oliguric, potassium isn't effectively removed from the blood. Also, if the individual is hyperventilating, this can be a sign of metabolic acidosis, so an ABG is also done. AKI can lead to severe metabolic acidosis, where the pH dips below 7.1, because acid excretion is impaired when there's a low eGFR. Next, urinalysis, both dipstick and microscopic examination of the urine sediment and urine sodium excretion, are done to help calculate the fraction of sodium excreted to sodium filtered, or Phen-A. In pre-renal AKI, the renin-angiotensin-aldosterone system is activated, leading to water and sodium retention. So, the BUN to creatinine ratio is usually over 20:1. The urine osmolality is over 500 milliosmoles per kilogram. The urine sodium excretion is less than 20 milliequivalents per liter, and the Phen-A is less than 1%. With intrarenal AKI, filtration, reabsorption, and secretion can all be affected. As a result, the BUN to creatinine ratio is usually below 20:1. Urinalysis results can vary based on the cause, but generally, the urine osmolality is below 500 milliosmoles per kilogram, because water isn't as well retained. In acute tubular necrosis, on microscopy, there are muddy brown, granular epithelial cell casts, along with renal tubular epithelial cells. In glomerular nephritis, there's usually hematuria and proteinuria. Additionally, on microscopy, there are dysmorphic red blood cells and red blood cell casts. In glomerulonephritis, an additional workup includes a 24-hour urine collection, serology, and a kidney biopsy to identify the underlying cause. In acute interstitial nephritis, the CBC shows eosinophilia. On the urine dipstick, there may be hematuria, proteinuria, and pyuria. On microscopy, there are white cells, white cell casts, and red blood cells. With all types of intrarenal AKI, urine sodium excretion is typically above 40 milliequivalents per liter, and the Phen-A is above 1%, because sodium isn't effectively reabsorbed. Finally, there's post-renal AKI. If the obstruction damages the tubules, then reabsorption is affected, so the BUN to creatinine ratio falls below 20:1, and the urine osmolality is below 500 milliosmoles per kilogram. Urine sodium excretion is typically above 40 milliequivalents per liter, and the Phen-A is above 1%, because sodium doesn't get reabsorbed. When the tubules are functioning, urea, water, and sodium can be reabsorbed, so the BUN to creatinine ratio is above 20. The urine osmolality is over 500 milliosmoles per kilogram. Urine sodium excretion is less than 20 milliequivalents per liter, and the Phen-A is below 1%. In both situations, on urinalysis, there can be hematuria. Sometimes, an obstruction can lead to an infection, so there may also be pyuria. An additional workup includes obtaining serum prostate-specific antigen, or PSA level, which is elevated with prostatic disease, both benign prostatic hyperplasia and prostatic cancer, as well as imaging. An abdominal ultrasound can help identify proximal ureter stones and hydronephrosis, and a non-contrast CT scan of the abdomen and pelvis can help identify abdominal tumors or stones along the urinary tract, including the urethra. AKI can lead to various complications, such as volume overload, hyperkalemia, severe metabolic acidosis with a pH that's below 7.1, and signs of uremia, like uremic pericarditis, where the pericardial sac gets inflamed, causing chest pain. In this case, an echocardiogram is done, and this typically shows a pericardial effusion. Treatment relies on urgent dialysis or temporizing measures until dialysis can be arranged. Temporizing measures include administering IV diuretics, like furosemide when an individual is fluid overloaded, administering IV bicarbonate when the pH is below 7.1, and administering IV calcium gluconate along with IV insulin plus glucose, and IV furosemide when there's hyperkalemia with potassium levels above 5.5 milliequivalents per liter. With any type of AKI, it's important to identify and treat the underlying cause. Now, with prerenal AKI and intrarenal AKI that's caused by acute tubular necrosis and interstitial nephritis, the goal is to carefully manage the body's fluids while the kidneys heal and recover. With intrarenal AKI caused by glomerular disease, treatment relies on identifying and treating the condition. Finally, with postrenal AKI, treatment relies on identifying and removing the obstruction. Now, there are some general principles that are taken into consideration with any type of AKI, regardless of stage. First, all nephrotoxic medication is discontinued and radiocontrast procedures are avoided, since that can worsen the renal function. Next, the individual's hemodynamic status is monitored. If the individual has signs of hypovolemia, like hypotension, then IV saline is given to restore intravascular volume. Normally, that helps stabilize the blood pressure, but if an individual is persistently hypotensive, then vasopressors like IV norepinephrine may be needed. Now, on the flip side, if the individual is hypervolemic, then IV diuretics, such as furosemide, are given. In critically ill individuals, invasive hemodynamic monitoring is done using an arterial line, central venous pressure, and cardiac monitoring. Serum creatinine levels and urinary output are usually monitored every few hours. Blood glucose is also monitored because hyperglycemia can cause an osmotic diuresis, which further damages the kidneys. Additionally, with stage 2 AKI and stage 3 AKI, the dosage of medication should be adjusted according to eGFR. Alright, as a quick recap, AKI is diagnosed